Good morning. I'm Henry Ginsberg. I'm a professor of medicine at the Vagelos College of Physicians and Surgeons of Columbia University, and it's my pleasure today to serve as the moderator for this webinar. Welcome and thank you for joining the American Heart Association for this educational webinar for healthcare professionals. The webinar is titled Lipoprotein A, an atherosclerotic cardiovascular disease risk factor that can no longer be ignored. This is the first of two webinars that we will present on LPA, and they will focus on LPA and peripheral arterial disease, as well as all the other forms of ASCVD. The activity is funded by an independent medical education grant from Canica Corporation. It is important to note that the program has been developed completely independently of any outside sponsorship. A quick review of the agenda, and I'll go into a little more detail as we move along, is shown here. We'll have learning objectives reviewed for a moment, introduce the faculty, some housekeeping details, and then the presentations. There'll be three of them, as you can see here, and then a question and answer period. And you'll hear this a few more times because we really want participation from the audience. That there is somewhere on your screens, depending on your computer setup, you'll see a Q&A. It's alongside participants in the chat icons. There's a Q&A icon that allows you to drop questions to us throughout the presentations. The objectives today are to identify the biology of lipoprotein A, LP little a, to recognize the relationship between LPA and atherosclerotic cardiovascular disease, ASCVD, specifically in this case of this webinar, peripheral artery disease, PAD. And finally, to evaluate ASCVD risk in individuals with elevated LPA. Here is the faculty. And as I mentioned, I'm Irving Professor of Medicine. I was director of the Irving Institute for Clinical and Translational Research at Columbia University for many years, now back in my laboratory and my clinical. We also have Pia Kamstrup, head of the Department of Biochemistry at Copenhagen University Hospital, and Mark Banaka, executive director of clinical research and community health, School of Medicine at the University of Colorado.
Well, hello, everybody. It's such a pleasure to be here today and participate in this educational webinar. And as Henry just mentioned, I'm from Copenhagen University Hospital, and I'm also a professor at the University of Copenhagen Institute of Clinical Medicine. I've been working with Lp(a) for the past more than 15 years. In the field of genetic epidemiology, and specifically working with some of our large Danish general population studies. And I look forward to sharing some of our results from those studies with you.
Disclosures are presented here. You won't be tested on this at the end of the presentations. And again, please note that Q&A icon at the top of your screen or at the bottom of your screen, wherever your other icons are located, allowing you to ask questions at any time. And we will try to reach, we have a very, very large audience today, over 500 registrations were counted, and we will hopefully get to as many questions as we can. So I'd like to get us started with a brief overview of lipoprotein A, and I've been very involved in this field for about the last 25 years, scientifically, clinically, and even personally. And looking at this field, I was initially very surprised to find out that LPA, which is just now emerging in many places around the world, particularly in the area of clinical cardiovascular disease, was identified as a new type of lipoprotein in first paper being published in 1963 by Kara Berg and colleagues in Norway. He was an immunologist actually looking for new types of lipid-associated proteins and identified what he called, based on immunologic classification systems, small a, leaving us with lipoprotein little or small a. Importantly, and you'll hear much more about this from Pia, is that LPA may be very similar for the most part of its structure with LDL, but it's that small a protein shown here wrapped around the LDL particle that changes its biology quite dramatically, the biology, the physiology, and its role as an atherosclerotic risk factor. Getting back to when Dr. Berg first identified LPA is shown here by this roadmap of publications and implementation guidelines is so striking. So he identified, the first paper comes out in 1963, and not much happens for the next 20 years. A few people around the world, particularly in Europe, including his own group, find associations with family inheritance, with ASCVD, but not until the late 80s when LPA is purified in a few labs, and then we get the cloning of the LPA, all capitals, gene, the gene that produces the small a protein, do we get a burst of interest, then a sagging again, and now most recently, a steady rise in publications. And at the bottom of that road on the right side, we see the initial edition of guidelines for LPA within usually the guidelines for the treatment of lipid risk factors or atherosclerotic cardiovascular disease. And one of the most interesting, but also adding to the complexity and the difficulty in thinking about LPA, is the many, many activities based in human studies, in large and small animal studies, although not many small animal models exist, and in cell work of all the potential mechanisms where Lp(a) can be involved in cardiovascular risk, in atherogenesis, and in events of atherosclerotic cardiovascular disease. And I will then move on, and we will have our two presentations, first by Pia Kamstrup and then by Mark Banaka.
Thank you to the organizers for the opportunity to contribute to this highly relevant educational session and give a talk on lipoprotein(a), an atherosclerotic cardiovascular disease risk factor that can no longer be ignored. Now, the topic of the present webinar is thus lipoprotein(a), also known as Lp(a). I will provide you with an overview of the Lp(a) particle structure, its secretion and removal from circulation, touch upon Lp(a) heritability, and give an overview of the genetic epidemiologic evidence of Lp(a) as a causal risk factor for cardiovascular disease, including peripheral artery disease. Now, Lp(a) is synthesized by the liver and consists of a cholesterol-laden LDL-like particle covalently bound to the plasminogen-like lipoprotein apolipoprotein(a). While plasminogen consists of 5 different crinkle-shaped protein structures, 1 through 5, and a protease domain, apolipoprotein(a), coded for by the LPA gene, consists of several plasminogen-like crinkle 4 structures, types 1 through 10, one plasminogen-like crinkle 5 structure, and an inactive protease domain. Notably, the number of crinkle 4 type 2 structures vary between 2 and more than 40, and the Lp(a) particle thus occurs as differently sized particles, with most individuals expressing 2 different isoforms, one from each Lp(a) gene allele. Now, the liver is also considered the primary site of Lp(a) catabolism. Zooming in on Lp(a) production and catabolism, the assembly of the intact Lp(a) particle from apolipoprotein a and the LDL-like moiety likely occurs intracellularly or on the surface of hepatocytes, with possible contribution from recycled apolipoprotein a, as indicated on this figure. Now, the rate of assembly and secretion of Lp(a) is mainly determined by the size of the Lp(a) gene transcripts, with greater retention and thus less excretion of large apolipoprotein a isoforms. As also shown on this figure, multiple hepatocyte receptor-mediated pathways have been implicated in Lp(a) particle catabolism. And implicated receptors include the LDL receptor, scavenger receptor B1, and the plasminogen receptors PLGR and PLGRKT. However, controversy still exists, and in vitro findings are not always consistent with findings in humans. Thus, in a large Danish general population study, we did not find elevated Lp(a) levels in individuals with an LDL receptor mutation prevalent among familial hypercholesterolemia patients with genetically determined high LDL cholesterol levels. The precise mechanism of Lp(a) catabolism is thus still unknown. Now, as demonstrated by the Lp(a) concentration distribution, here derived from a large sample of the Danish general population, Lp(a) levels vary widely between individuals. Importantly, Lp(a) particle size correlates inversely with plasma Lp(a) levels, as large apolipoprotein a isoforms are more prone to intrahepatic retention and degradation, and thus Lp(a) levels are primarily genetically determined by variation in the Lp(a) gene. Now, in addition to the Lp(a) crinkle 4 type 2 copy number variation determining apolipoprotein a isoform size, a number of single nucleotide polymorphisms, or SNPs, in the Lp(a) gene, some partly tracking the copy number variant, are also strongly associated with plasma Lp(a) levels. On the right, Lp(a) plasma levels are shown as a function of the number of crinkle 4 type 2 repeats in percentiles, and additionally stratified by carrier status for 2 common Lp(a) SNPs. Now, for each category of SNP carrier status, we see the inverse association of number of crinkle 4 type 2 repeats with plasma Lp(a) levels. Carriers of minor allele SNPs with low number of crinkle 4 type 2 repeats have the highest plasma Lp(a) levels. Now, while the genetic variants are not independent, all contribute information, and genotyping for just these 3 variants explains 45% of the total variation in levels, clearly demonstrating that Lp(a) plasma levels are very much genetically determined by variation in the Lp(a) gene. Now, while Lp(a) levels do vary widely between individuals, the intra-individual variation is relatively modest, with levels being remarkably stable throughout life, as shown on the right, with age on the x-axis, and Lp(a) levels in milligrams per deciliter and nanomoles per liter on the y-axis, but with the notable exception that levels do increase somewhat in women at the time of menopause. Thus, high Lp(a) levels are relatively more frequent in women than in men after the age of 50. Furthermore, in individuals of European descent, the Lp(a) concentration distribution is highly skewed, with a long tail stretching out towards high and extremely high levels, and approximately 20% of the population has elevated levels. In other ethnicities, the concentration distribution may be less skewed, and median levels also vary with ethnicity. Finally, what about Lp(a) levels in children? Now, this slide depicts data from the Copenhagen Baby Heart Study Compare sub-study with Lp(a) levels available in 450 trios. Left is the Lp(a) concentration distributions at birth and at 2 and 15 months of age. Now, the shape of the distributions closely resemble what is found in adults, although levels are very low at birth and at 2 months, while levels already at 15 months start to approach adult levels. Notably, birth levels above the 90th percentile predicted Lp(a) above 42 milligrams per deciliter at 15 months. 42 milligrams per deciliter corresponding to the 80th percentile in the adult Danish population, indicating that already at birth it is possible to identify children who will grow up to have elevated levels. Further, birth levels above the 90th percentile predicted at least one parent with levels above 42 milligrams per deciliter with a positive predictive value of 75 to 83%, opening opportunities for reverse cascade screening. Therefore, what constitutes elevated Lp(a) levels in infants is at much lower plasma concentrations than in adults, e.g. already at levels above 5 milligrams per deciliter, corresponding to approximately 11 nanomoles per liter. Now, in a global perspective, the highest median Lp(a) levels are thus found in Black individuals of African descent, while individuals of East Asian descent have the lowest levels. The difference results primarily from higher levels of Lp(a) being associated with medium-sized apolipoprotein a alleles in people of African descent. Globally, an estimated more than 1 billion individuals have high Lp(a) and thus increased risk of ASCVD on this background. Now, we have used a large Danish general population study to examine the associations of high Lp(a) levels and corresponding Lp(a) risk genotypes, determining high levels with risk of morbidity and mortality. Now, the Copenhagen General Population Study was initiated in 2003 with approximately 10,000 participants enrolled yearly and with follow-up available on all participants until 2018 through Danish nationwide registries. All participants have answered questionnaires, had a physical examination, and had blood drawn for biochemical and DNA analysis. Now, this slide depicts risk estimates from myocardial infarction. We see a stepwise increase in risk with increasing Lp(a) levels. Notably, while risk starts to increase already at moderately elevated levels in the top third of the concentration distribution, it is apparent that markedly increased risk is exclusively found for high and extremely high levels. Thus, Lp(a) levels above the 90th percentile predict 2 to 3-fold increases in MI risk as compared to risk in individuals with levels in the lower third of the concentration distribution. Likewise, for calcific aortic valve stenosis, high and extremely high Lp(a) levels have been found to associate with 2 to 3-fold increases in risk, and with risk increases already seen at moderately elevated levels, that is in the top third of the concentration distribution. Further, multivariable adjustment for conventional risk factors have very little effect on risk estimates for elevated Lp(a) levels. If anything, point estimates go up upon multivariable adjustment, as shown on this slide on the right. We have recently also assessed risk of incident peripheral artery disease and risk of abdominal aortic aneurysm in our general population studies. And here we also observe stepwise increases in risk with increasing Lp(a) levels as seen on this slide. However, risk estimates are perhaps not quite as high as those found for MI and calcific aortic valve stenosis, as 2 to 3-fold increases in risk are only found for individuals in the top 1% of the concentration distribution, that is in individuals with levels exceeding 140 milligrams per deciliter, corresponding to approximately 300 nanomoles per liter. Now, while the highest risk estimates have been found for myocardial infarction, calcific aortic valve stenosis, and PAD, as summarized on this slide, high Lp(a) levels additionally associate with increased risk also of incident heart failure, ischemic stroke, and cardiovascular and total mortality. However, for these endpoints, Lp(a) levels typically have to be in the top 5 or top 1 percentile to translate into clinically relevant risk increases, as illustrated on this slide, depicting adjusted hazard ratios for high and extremely high Lp(a) levels in the Copenhagen studies. Importantly, risk estimates for high Lp(a) are largely independent of conventional cardiovascular risk factors, as demonstrated here, with relative risk estimates for cardiovascular or all-cause mortality for high Lp(a) shown, and stratified by the presence or absence of conventional risk factors, including sex, age, LDL and total cholesterol, BMI, smoking status, and hypertension. In nearly all subgroups, risk estimates for high Lp(a) are similar, with no statistical evidence of effect modification found for any conventional risk factor. Further, at least in a general population setting, risk estimates for high Lp(a) appear independent of the presence of systemic low-grade inflammation as marked by elevated C-reactive protein levels, with similar risk estimates for ASCVD, MI, and calcific aortic valve stenosis in individuals with low or elevated C-reactive protein levels, as shown here. Finally, for all these disease endpoints, genetic evidence of causality exists, as Lp(a) risk genotypes determining high Lp(a) levels have also been found to associate with increased risk of each disease endpoint. An example of the strong genetic evidence of causality that exists for Lp(a) and disease associations is shown here from our cardiac infarction. The figure shows increasing plasma Lp(a) levels as a function of decreasing number of crinkle 4 type 2 repeats in the Lp(a) gene, and the concomitant increase in risk of MI is shown on the right. Now, the association of Lp(a) genotypes determining plasma Lp(a) levels with risk of disease represents strong genetic evidence of causality, as it cannot result from reverse causation, as disease does not affect genotypes determined at conception, and thus the association is likely unconfounded by conventional risk factors due to the random distribution of risk genotypes in homogeneous populations. A second example of genetic evidence for causality is shown here for PAD and abdominal aortic aneurysm, where Lp(a) genotypes determining elevated Lp(a) plasma levels associate with increased risk of both PAD and abdominal aortic aneurysm. Now, while most data on Lp(a)-associated risk stem from primary prevention study populations, as the data just shown, some data from secondary prevention populations are available. In the Copenhagen General Population Study, stepwise increases in risk of recurrent major adverse cardiovascular events with increasing Lp(a) levels have thus been demonstrated in 2,500 participants with existing CVD prior to study inclusion, and as shown on the left, with twofold increases in risk of recurrent MACE found for individuals with levels above 100 milligrams per deciliter. Additionally, in the large cardiovascular Odyssey outcome trial targeting LDL cholesterol with a PCSK9 inhibitor in existing cardiovascular disease, a clear stepwise increase in risk of cardiovascular events was seen with increasing Lp(a) levels in the placebo group, as shown here on the right, and with 1.6-fold increases in risk found for levels above 60 milligrams per deciliter. Finally, while the majority of the data shown so far stem from studies conducted in predominantly white European ancestry populations, and Lp(a) concentrations and levels, concentration distributions and levels are known to vary with ancestry, a recent very large study on 460,000 individuals from the UK Biobank included also a significant number of self-identified South Asian and Black and a smaller number of Chinese participants. While median Lp(a) concentrations varied according to race, ethnicity, as shown on the left side of the slide, and as demonstrated by different thresholds for race-specific 90th percentile cut points, no significant differences in risk estimates were found, as shown top right, when using a uniform cutoff value for high levels of 150 nanomoles per liter or a race-specific 90th percentile. Further, a similar log linear rise in ASCVD risk of 1.1 per 50 nanomoles per liter Lp(a) concentration increase was found across racial ethnic subgroups, and with no biologic evidence of a threshold for increased risk found. These data thus indicate that risk findings for high Lp(a) appear widely applicable across racial ethnic subgroups. So far, relative risk estimates for high Lp(a) have been presented, and with similar estimates found when only adjusting for age and sex and when additionally adjusting for conventional risk factors. It is, however, important to keep in mind that an individual's absolute risk of CVD is dependent on the combined contribution of all risk factors illustrated on this slide, with data from the Copenhagen City Heart Study and with data from the UK Biobank. While stepwise increases in risk are seen for both low and high risk groups based on conventional risk factors, the highest absolute risk is not surprisingly seen in individuals with both conventional risk factors and high Lp(a). These data also clearly illustrate that failure to consider an individual's Lp(a) level can lead to a substantial underestimate of their absolute risk of CVD. Now, key takeaways from the present presentation include that high Lp(a) is a genetically determined, common, independent, and causal risk factor for ASCVD, calcific aortic valve stenosis, and mortality. That cardiovascular risk increases as Lp(a) levels above 30 milligrams per deciliter, and even more at levels above 50 milligrams per deciliter. That Lp(a) levels in the top 10% of the concentration distribution predict 2 to 3-fold increases in risk of coronary heart disease, peripheral arterial disease, and calcific aortic valve stenosis. And that absolute CVD risk is dependent on conventional cardiovascular risk factors and Lp(a) levels. Thank you for your attention.
Thank you so much, Pia, for outstanding presentation. Distilling an enormous amount of data into a concise and I believe quite understandable and clear presentation. And it is amazing how much progress has been made once the gene was cloned and the KFOR2 repeat story became evident, and using that along with better assays over the last 25 years, collecting all the data from large databases. We're now going to hear from Dr. Mark Banaka, his presentation on LPA and peripheral, focusing on peripheral artery disease. And then after that, we'll have the question and answer period.
Hi, my name is Mark Banaka. I'm a cardiologist and vascular medicine specialist at the University of Colorado, and I'll be talking about Lp(a) and the vascular patient. I want to begin with the recognition that atherosclerosis is a systemic disease. It can manifest symptomatically in different territories. About 230 million people globally suffer from occlusive disease in the lower extremities, or what we call peripheral artery disease. And many people refer to this as the most malignant form of atherosclerosis or metastatic atherosclerosis. PAD is prevalent, particularly in people who have risk factors. And if you look at the bottom of this slide, patients who are of older age or who have a history of diabetes or smoking are at the highest risk. And you can see in the partner study, about 1 in 3 individuals meeting those criteria had PAD, although many of them didn't recognize it. Overall, in the US, it's estimated that around 8.5 million have the diagnosis of PAD, but there are likely many more that are undiagnosed. It's important to recognize that peripheral artery disease is one of the core manifestations of cardiometabolic disease or diabetes, that in patients who have type 2 diabetes, the most frequent first manifestation of cardiovascular disease is peripheral artery disease, as you can see in the red, even more than heart failure or non-fatal myocardial infarction. We know that patients with PAD have poor outcomes. In fact, in trials like the 4A trial shown here, the patients who are enrolled with peripheral artery disease had a higher risk of CV death, MI, or stroke than those patients who entered the trial with actually a prior MI or a stroke. And this is a much higher risk, almost double. And we know that that risk is heterogeneous, that it is the patient with polyvascular disease, those with symptoms in the legs as well as a history of MI or stroke together, that have the highest risk, you can see in the red line. But even those patients with PAD alone that have never had an MI or stroke are at higher risk of having an event than those who have. And so it's important to recognize patients with PAD because of their risk of MACE. But the most important morbidity in the patient with PAD is the lower extremity morbidity. And you can see this sort of patient journey as the disease progresses from left to right on this slide. Many patients begin with mild functional symptoms that they do not attribute to vascular disease. that then progresses to more severe symptoms. Sometimes they come to recognition when they need to have a revascularization or they have an ulcer or gangrene on the toe. And certainly those patients who present needing an urgent revascularization or come with acute limb ischemia or critical limb threatening ischemia are the highest risk patients. Our goal in prevention is always to find and treat people at the left side of the slide, but unfortunately in the context of PAD, many patients show up at the later stages of diseases. One of the most feared manifestations are what we call major adverse limb events, and those can include things like amputation, and then the acute thrombotic occlusion of a leg artery. That's called acute limb ischemia. It's like the ST elevation MI in the heart, where you have occlusion of an artery and threatened viability of the lower extremity, and outcomes after acute limb ischemia are poor. Unfortunately, this is a frequent manifestation of PAD along with critical limb threatening ischemia. And so when we look at the totality of risk in the patient with PAD, while I showed you in the Fourier trial, they're at very high risk of major adverse cardiovascular events, shown in the red bars here in the REACH registry, and then a randomized trial called TRA2P on the right. The dominant cause of morbidity in this population actually is amputation, acute limb ischemia, and the need for a procedure to restore perfusion due to either threatened tissue loss or limiting occlusive disease. So how do we treat PAD? Well, there's multiple axes of risk. You can see a nice genetic study on the left looking at the specific genetic polymorphisms, and then the correlates on the right. And so the lifestyle is the foundation: exercise, supervised exercise, diet, smoking cessation. Lipid risk, we know that LDL and LPA are both associated with poor outcomes in treating lipid risk. Diabetes risk and microvascular disease that leads to retinopathy, kidney complications, and lower extremity ulcerations, inflammatory risk, and then thrombosis risk. In terms of Lp(a), there have been several observational studies that have shown a clear relationship between LPA and peripheral artery disease. Here from Epic Norfolk, you see that elevated LPA is associated with an increased risk of incident PAD, so people developing manifestations and being diagnosed with PAD. And you can see this was clear at a level of about 50 milligrams per deciliter. We also know that LPA is important for the progression of other diseases, not just PAD, but has been associated with progression of calcific aortic valve disease. And while these may seem unrelated, the notion of calcification in the lower extremities is a major issue, and many of these patients have the shared comorbidity of PAD and aortic valve disease. We know that in those with PAD, lipoprotein A is associated with increased risk of major adverse limb events, as well as abdominal aortic aneurysms and prevalent disease. We can see here the risk associated with the different cut points in both in nanomole per liter and in milligram per deciliter, and that there's a risk, about a threefold risk of both the development of PAD, but also the incidence of major adverse limb events in those with known PAD, as well as aortic aneurysm. And in patients who have PAD, LPA is associated with a more malignant form of the disease. And so here, in a nice anatomic study using a vascular classification system called TASC, you can see that patients who had class D or more complex disease versus A through C had higher levels of lipoprotein A, and that those who had more severe calcification, as I alluded to with the aortic disease or aortic valve calcification, it's also associated in PD with more severe disease, more calcific disease. We know, I showed you on the prior slide, that it's associated with poor outcomes. Here in a study of around 1,500 patients with PAD, you can see the tertiles of lipoprotein A, and those who had levels, again, above 50 milligrams per deciliter had very high rates of amputation relative to those without at a time of around 36 months. We also know that from randomized trials that patients who have elevated lipoprotein A not only have higher risk, but they may derive greater benefit from certain therapies. So this is data from the Odyssey Outcomes trial, a trial that looked at alirocumab, a PCSK9 inhibitor that lowers LDL and has a modest effect on LPA. And what you can see by quartile of LPA here with regard to limb events is that despite the fact that the LDL lowering is the same in all of these, that the LPA lowering is obviously higher in those with higher LPAs, and the benefit of the drug appears greater with a significant trend across these quartiles. And this suggests that the patient with high LPA is not only higher risk, but may derive even greater benefit from intensive treatments such as PCSK9 inhibition. Here are some observational data from a group of trials aggregated looking at major adverse limb events. This is around 30,000 patients. These data were presented at the ESC, again showing a continuous relationship between lipoprotein A and major adverse limb events. And in the PAD patients, the median was around 36 nanomoles per liter. When you put this into context as a continuous variable, we are all very aware of the risk of MACE, but the risk of MALE has a very close association with LPA of a magnitude that is as strong as that seen for MACE. And so that limb outcome should be very much on the mind of clinicians identifying patients with PAD and high lipoprotein A. And this is consistent across the different components of the MALE outcomes, including the need for repeat revascularizations, critical limb ischemia, and composites of adverse limb events. We know that patients who have PAD that require revascularization have worse outcomes if they have an elevated lipoprotein A, and this is a large study that was published showing the association of outcomes based on LPA levels over about 14 years of follow-up. And you can see the groups were stratified at 30 milligrams per deciliter, so relatively low concentration of LPA, but still significantly associated with outcomes. We know the same has been observed for endarterectomy, that the patient with an elevated lipoprotein here at 25 nanomoles per liter had worse outcomes after endarterectomy, and again, over a number of years, almost a decade of follow-up. Here we have another look at endovascular repair, and this analysis published in JACC, again with a cut point relatively low, 30 milligrams per deciliter. Those patients with PAD had higher risk of MACE and MALE with elevated LPA, but the relationship was stronger for limb outcomes, as you can see on the left side of this slide. And those patients who had an elevated LPA did much worse after endovascular repair than those who had a low LPA. I showed you data from the Odyssey trial with alirocumab. Other therapies have been shown to reduce MALE in the lipid space. This is data with evolocumab from the Fourier trial. LDL lowering resulted in about a 42% reduction in major adverse limb events with consistent effects across all of the components of major adverse limb events. Again, this is a PCSK9 inhibitor that lowers LDL by about 60% and has some modest effect on LPA. And so when you look at Fourier on the left and Odyssey on the right, you see striking consistency for the PAD patients, that they are high risk, they derive a large absolute risk reduction from MACE, and that they are at high risk of major adverse limb events, and the pattern of benefit is seen early and robust over time. Now, whether the benefit of the PCSK9 inhibitors for limb outcomes in PAD is driven by LDL alone, or whether the LPA is a marker of more LDL sensitive patients, or whether the LPA lowering has a synergistic effect is unclear. But we see consistent effects across the trials that both lowering LDL and LPA, and particularly a high baseline LPA, identifies patients that are higher risk and derive an even greater benefit. We see this across different vascular events. In this analysis from the Fourier trial, we see this for venous thromboembolism, another thrombotic vascular event. And here we also saw that the effect appeared to be most closely associated with LPA and not as much LDL levels, suggesting that perhaps there's a prothrombotic component of LPA, and that lowering with PCSK9 inhibitors seems especially beneficial for this outcome in those with high LPA. Again, here's a meta-analysis of the two trials, the Fourier and Odyssey trials, showing you this risk reduction VTE with PCSK9 inhibition, the consistency amongst the trials, and the greater benefit in those with higher baseline LPA. So I've covered a bunch of data. I think the take-home message is that PAD is prevalent. It's often underdiagnosed. It is associated with very high rates of MACE, and in addition, major adverse limb events. that there's a close association between LPA and the development of PAD and worse outcomes for both MACE and limb outcomes in those with PAD, both in stable chronic patients as well as post-revascularization. So how do we think about this in the context of clinical care? Well, this is a patient that I saw, 50-year-old man who was really in good health. He came to the emergency room with a cold right leg that was in severe pain. A CT angiogram showed a thrombotic occlusion of the common femoral artery and the superficial femoral artery profunda, as well as some clot in the popliteal disease. You can see an ultrasound image on the right. He was treated with thrombolysis, and the limb was salvaged. You can see his profile on the left side of the slide. The LDL was 148, the blood pressure 118/60, normal EGFR, no diabetes, non-smoker, normal body weight, was quite athletic. He was treated intensively, as you can see on the bottom of the slide. Thrombophilia workup was done because this was such a dramatic event and was all negative. And so, despite his high LDL, he was a healthy individual. It's an unusual event. He was treated with medical therapy. 2 years later, he came in after having chest pain. He'd been mountain biking, lives in the mountains. It was progressive, and he presented to the emergency room and was diagnosed with a myocardial infarction. And this is 2 years after his limb outcome, and he was 52 years old. He was flown down to the Metro Denver area where I practice, and you can see some images from his angiogram here. But at 52 years old, he had multivessel coronary disease and was treated with bypass surgery. On presentation, his LDL was 63 milligrams per deciliter. He was adherent to his statin therapy. It was less than the 70 milligram cut point, but above 55, still not terribly elevated, normal A1C, normal body weight. And he said to me, why is this happening to me? I've always lived a healthy lifestyle. I've never smoked. I've now had this, limb outcome, and I've now had multivessel coronary disease. And so, this really raised the question of when to check LPA. I think the future state is that everyone should have it checked once in a lifetime. It's genetically determined. I do check it in all my patients. But in the vascular practice, when you see a patient like this who's got either early onset disease, an unusual presentation of acute limb ischemia, let's say at a young age, or a severe disease, if you see PAD in the context of aortic stenosis or an aneurysm, you should be thinking about it. This poor individual had a very malignant, presentation of multiple events, recurrent events, and I would check an LPA there. Poor outcomes after revascularization. And then I think disease in the absence of our traditional risk factors. This patient was young, never smoked, no diabetes, very unusual to have PAD. Those are patients absolutely should have an LPA checked. If not everyone, certainly check these patients who have these malignant phenotype. So we measured LPA, and it was very high. It was a clear uncontrolled risk factor. He had an elevated level. We discussed the importance of family screening. We intensively lowered LDL. We added a PCSK9, now with an LDL of 10 milligrams per deciliter. We discussed other options like protein pheresis or plasma pheresis, and he's on the waiting list for a clinical trial. So I want to thank you for your attention today. I look forward to the discussion. Hopefully this provided some information around the role of LPA in the risk of patients with peripheral artery disease. Thank you.
Thank you, Mark, taking on the second half of the story and the one more focused on clinically relevant vascular disease in individuals who are always the people that we see and the best examples of what a risk factor can do to people. We have time now for questions. In case there were none, we have our own that we developed. And so first question, and anybody of the three of us can take this, so we can all do it, is if my family has a history of a stroke or coronary artery disease or peripheral vascular disease, should I have my LPA level checked? Pia.
Well, as Mark mentioned, guidelines internationally speaking are transitioning towards recommending Lp(a) measurements once in a lifetime in all adults. That's not the case right now for US guidelines. They are more focused, not all of them at least, on looking at risk patients. And a family history is certainly a good reason for an LPA to be checked. So I would say, yes, it's a good idea to check an LPA here.
Yeah, and I would add to this, it's been very disappointing that in the US, the guidelines have lagged behind just about the rest of the world that has guidelines, certainly the European Atherosclerosis Society, the Canadian Atherosclerosis Society, the International Atherosclerosis Society, all recommend once in a lifetime. If you remember Pia's data, you have at birth. It may be low for the first couple of years, a year and a half, whatever, but if it's high percentage while at birth, it's going to be at the highest percentage when you're older. And the question would be, well, why not wait? And that's a question that we've dealt with LDL for many years. And we know that in monogenic familial hypercholesterolemia, treatment of young children, adolescents certainly, and young adults has a much better outcome than waiting until they're 40 or 50 years of age and have an event. And I think we should see LPA as a monogenic disease of atherosclerosis the same way. You're born with that level and it needs to be treated. And I would also point out that in several studies now, we have one at Columbia that's not published, but there are now published studies with rather vague guidelines in the US. If you use criteria in the AHA-ACC guidelines in 2018 of who might get an LPA measured, that leads to a situation where almost no one gets it measured. 2% of people in 3 large studies, approximately 2% of people who met those AHA-ACC guidelines had an LPA done based on electronic health records. They're just terrible, just terrible. What are the symptoms of a high LPA level?
Well, Henry, I mean, as we're all aware, there are no symptoms until you have an ASCVD event. So that's the tricky part. And that's why some may argue that it's even a little bit unethical to wait until you have your event to actually get it measured. Yeah.
I've always told patients for several decades that I wish a high LDL would cause a headache or a toothache, and they go to a doctor. And LPA is in that same category. It's a silent disease. It's a silent killer in the worst instances. And again, it means that certainly people who have events and people who have other risk factors, that's the first stage, but it's a minimal approach, a minimalist approach. And it's one test, one time, and not very expensive. If your LPA is high, will your LDL level also be high? It's maybe the most complicated question we have.
Well, if I have to give one answer, I would say no, because I mean, if you do have very high Lp(a), of course, there is a limit to how low you can go with very aggressive treatment, because some of your cholesterol and the LDL cholesterol fraction will be from Lp(a). But the Lp(a) particle, it's discussed how much the cholesterol content is. I think it's safe to say that it's at least approximately around 15–20%, that's cholesterol content, but it varies a lot and we don't really have that good data. But if you take 20% of an Lp(a) measurement of 100 milligrams per deciliter, then you have 20 milligrams per deciliter of your LDL cholesterol, which is actually Lp(a) cholesterol. So no, you don't necessarily have what you would consider a high LDL cholesterol if you have high Lp(a), but you will not be able to reach perhaps extremely low LDL cholesterol levels because with statin treatment, for instance, because it does not affect Lp(a) levels. Henry,
no, I think
perhaps you will make my answer more understandable.
No, I think, well, I'm not sure if when you were talking, Pia, but when you think about those cartoons of LDL versus LPA, there's an ApoB on LDL, there's an ApoB on LPA, and if you measure ApoB and do some arithmetic, even people with LPAs at the 80th and 90th percentile, without treatment of an LDL, just their naturally occurring LDL, and let's say in the US, the median LDL cholesterol or the median ApoB might be at 100 milligram per deciliter. Their LPA is only a few percent, even 10 or 15, or maybe up to 20% of the particles that we call LDL are actually LPA. Now, if you take someone on 3 drugs after having events, and their measured LDL cholesterol is 20, and their ApoB might be also 20, but their LPA might be almost all that's there, actually. And that's what Pia was suggesting is you still have that risk factor then.
And it also, I mean, it points to the obvious fact that the atherogenicity per particle, LDL cholesterol or LP little a, or LDL cholesterol particles or LP little a, the atherogenicity per particle of LP little a is so much higher than that of the common low density lipoprotein. And that has been shown in different ways in many studies, and how much more atherogenic it is a matter of discussion. But some of the news results points to maybe it's a factor of 6. So that's something you should have in mind, that the per particle atherogenicity is higher for LP little a.
Right, and I would just put that in a slightly different context. If your LDL cholesterol is, again, average, your doctor says you're fine, and doesn't know what your LPA is, then your LPA could be 20% of those particles, but multiply that by 5 or 6, it's as much, you have another risk factor that's as potent as your LDL. And you don't know that. You can't say someone's lipid profile is perfect unless you know what their LPA is. You can't say their risk profile is great unless you know what their LPA is. It should be part of every risk analysis. There's a question about Raynaud's syndrome. I don't know if you have any data from all your cohort studies.
No, it's an interesting question. We don't have any data on it, and I'm not really sure how much is out there.
And then there's if my LPA is high and I've had events and I don't have a terrific drug right now, okay, the PCSK9s, they may actually get up to about 30% reduction, but most often they're in the 15 to 20, 25% reduction. What else can you do? What should your LDL goal be? If you're a physician, what's your LDL goal for your patients? If you're a patient, what should your physician be looking at? We have guidelines for LDL. They vary across different continents or countries. But if your LPA is very high in that top 20%, what is the guideline good enough for an LDL of 50 or 60 or 70? What should it be?
Well, I mean, the overall strategy, if you have high LP(a), should always be to aggressively target all other risk factors. Because I brought a slide where I show you absolute risk of an event for, say, the next 10 years. And it's very clear that an individual's absolute risk of an event is, of course, dependent on conventional risk factors and also LP(a) levels. And you can actually have quite high LP(a) levels and still be at a relatively modest absolute risk of event if you have no other conventional risk factors. So, I mean, the overall strategy in patients with high LP(a) would always be to aggressively target all modifiable risk factors, including LDL cholesterol. And I'm not really sure that we can look to the guidelines for an exact number for how low your LDL cholesterol should optimally be. I think that's a discussion you need to have with your physician, taking all your risk factors into account. But it should be aggressively treated if you have relatively high absolute risk. So Henry, what would you put an absolute number on it? You see patients?
When I have patients who are, quote, healthy, they haven't had an event, and they're, whatever their lipids are, I will take them to some point. But if they have a high LPA in the top 20, certainly the top 10 percentile, I'll go well below that. And we have been able to get PCSK9 inhibitors for some of those people if they have positive. I use the coronary calcium score here, not as an absolute divider of patients, because I probably treat all of them if I can, but certainly getting them covered by an insurance company, coronary calcium score is very helpful because that gives them coronary disease, although it's preclinical at that moment. And I have people certainly with events and even without events whose LDLs, as they're measured in the lipid profile, are down in the 20 to 30 milligram per deciliter range. And if they're on a PCSK9 to get there, their LPA might have fallen 20% as well. So I think absolute risk is something that is not well understood, and I think the slide that Pia showed is important. The absolute risk nearly doubled at every level of absolute risk if your LPA was in the top, 80 or 90th percentile. And that's over 10 years, and it's in a middle-aged group of people. Take that out to 30 years, and when everyone's absolute risk will be higher, and you're still going to be double. So, but hopefully we'll have the drugs.
Message. Yeah.
There was something. Oh, let's talk. I think we'll just finish up with talking about women. Postmenopausal women, where LPA seems to go up significantly as a group. How do we deal with that? And then ethnicity. And if I think, Pia, you made the point from the UK Biobank data that percentiles by percentile risk is as great if you're, regardless of your ethnicity and regardless of your not totally independent, but somewhat independent of your absolute risk. So if you had an African American person of African American ancestry and they had an LPA of 60 milligram per deciliter, is that the same as, is that not as bad as having a Caucasian at 60?
Well, it's you know as well as I, Henry, that perhaps we don't have we certainly as a scientific community would love to have more data from different ethnicities, but the data that is available, it does provide some support for at least some support for a uniform cutoff. So I would personally be very hesitant to say, well, you're safe because, due to your ethnicity, you would be in this percentile. I don't think there's basis for saying that. Right now, the data point to high Lp(a) is high Lp(a), regardless of your racial ethnic background. And we should use the same strategy. But I'm also acknowledging that we do not have as much data as we would like to have as of yet. Hopefully the future will bring that.
And for women, if you have postmenopausal women, you might take into account that their lifetime burden is not quite as bad as it would appear to be when they show up at age 65 and they have an LPA measured the first time. But it's not as if they went from an LPA of 20 to 100.
No. It's not that extreme an effect at all. It's just that we can see, you can also put it in a different way that after the age of 50, high Lp(a) is relatively more frequent in women than in men. But as long as we don't understand the exact mechanism of how Lp(a) drives the pathophysiological processes between ASCVD, it's tempting to speculate that the overall lifetime accumulated risk is lower in a woman with at the age of 60 with a level of 70 milligrams per deciliter than a man with a level of 70 milligrams per deciliter. But again, we don't really have the data to support that. And I mean, when we look in our cohorts, it is a general population study, and we have selected people based on basically a draw from the general population, but we have more elder individuals, middle-aged individuals than young, and we see that our relative risk estimates in women and men are similar. So that would perhaps argue against. So maybe there could also be some element of a threshold risk factor, perhaps related to a prothrombotic effect of high Lp(a). Yeah.
I think that brings us to the end of our time. There are quick bottom lines. Measure LPA in everyone you see who walks in your office. Once, you only need one. It's not expensive, and it could reveal somebody who's just waiting to have an event to happen. And you can then think about how to approach that. And secondly, of course, within 5 years, we'll have more than one drug. Hopefully they'll all be very positive in their outcome trials, and that'll change the face of this. And finally, you'll hear more, some of it the same, but much more new information that will provide you in our second webinar in September of 2024. And so for myself and for Pia Kamstrup and Mark Banaka, I hope you've enjoyed and learned much from this presentation. Take care.